What is up, guys, and welcome to another episode of the Equestrian Physio on Air. I'm Katie. I'm your host, a Canadian physiotherapist with a passion for empowering equestrians of all levels and disciplines with evidence-informed rehab, strength and conditioning, care, and education. And today, I wanted to dive a little bit more into the rehab side of things. So in our previous few episodes, we've been going through some basic strength and conditioning principles, my story, the psychology behind habit formation and training a little bit. And then today, I wanted to dip my toes in the rehab side of things and talk about some of the principles of musculoskeletal rehab. So these are the things that I will usually cover in education with my clients, or that I will use to kind of found my rehab practices, my rehab plans out of. So just as a disclaimer, I don't think any of you aren't aware of this, but just because I am a physiotherapist does not mean I am your physiotherapist, right? This is not medical advice. This is just education. It is not intended to be a substitute for professional medical consultation. So if you are dealing with pain, if you are dealing with injury, please go see your own provider. This type of content is intended to help give you an understanding, help inform you about how to manage your own care, how to self-advocate, what questions to ask, but this isn't meant to be a substitute for you seeking someone to actually help you and to give you individualized information. So with that said, without further ado, let's roll the tape. Hey, I'm Katie. I'm a physiotherapist, strength and conditioning coach, and lifelong rider dedicated to helping equestrians build strong, capable, resilient bodies, both in and out of the saddle. This podcast is here to empower riders of all levels with evidence-informed rehab, training, and education. And we're not just here to follow tradition for tradition's sake. We're here to challenge outdated norms and bring critical thinking and curiosity to how we train, ride, and show up. Let's get into it. So I want you to imagine a scenario. Like, imagine you have been riding for years. Most of you probably won't have to imagine, like, this will be pretty comparable to something that you already experienced. But like, imagine you riding for years, right? Everything you love is in the saddle. You love the sport. You love the community. You love working with your horse. You love the communication. But lately, things have been a little bit different, right? Every time you go to swing your leg over, you feel maybe an aching in your hip, a little bit of a sharp pain in your knee that wasn't before. Maybe your low back has been complaining. Mounting is becoming a little bit more of a struggle, and dismounting feels awful. So eventually you go to get it checked out. Maybe you get an x-ray and your doctor says you have hip arthritis, you have knee arthritis, you have degenerative disc disease. And, your mind starts racing, right? Is this the end of my riding? Your doctor starts saying things like, okay, you should avoid high impact, or you'll just have to live with this pain, or you have the back of an 80-year-old, or, oh God, I can't believe that you're still riding, or you definitely shouldn't ride. This is awful. Like, that's the worst thing you can do for yourself, and all these things start racing through your head. So it's easy to feel like your riding days are numbered, your sport days are numbered, that this diagnosis is now your life, it's your label. But the truth is very different. You're not defined by your diagnosis. Oftentimes, the thing that spurred pain, the thing that spurred a sudden onset of symptoms has nothing to do with the underlying tissue pathology, or it does, but there's layers to it. The underlying pathology has probably been there for a while. It's probably been developing for a long enough period of time. And now all of a sudden things have flared up for one reason or another. It doesn't mean that underlying pathology is still going to be limiting to you. So there's a lot that we can do to get you back in the saddle if these are the things that are running through your head, right? Whether it's arthritis, whether it's more of an acute injury like an ankle sprain, a rotator cuff tendinopathy or a flare-up, degenerative disc disease, anything in between. Hopefully this guide, we're mainly going to focus on like musculoskeletal stuff today, not getting into like neurological or pelvic health conditions or anything like that. But hopefully we can chat through some different concepts that will help you move forward and have a better understanding of some common misconceptions in rehab, some things that you can do for yourself, some basic foundational principles that you can use for your own rehab plan to help you manage your pain and your symptoms, help you adapt to movement, help you build strength overall so that you can keep doing what you love. You can keep riding, walking, engaging in the things that you really want to do without letting a specific diagnosis be the thing that holds you back. So I want to dive into a few general principles to rehab. And remember that rehab is not just doing exercises. It's not just soft tissue work. It's not just heat packs or cold versus ice. It is an understanding. It is about managing your pain. It is about taking control of your health. A lot of these things can help us along the way, but remember, they are just tools. The rehab process is us using modalities, exercises, education, all of these things to help your tissues heal or adapt in the most optimal way, to help your brain and your body kind of reconcile what's going on, and to help you adapt your life and your habits in ways that you need to recover from your injury or to recover from your pain. So a few things that we're going to go through just in terms of order, like we're going to start with some myths. And the first one we need to remember is that you are not your diagnosis. It can be really hard when you get handled a diagnosis to not feel overwhelmed. But remember that diagnosis is just one very small part of your story, right? It can feel all of a sudden like, oh, my doctor diagnosed with me with knee arthritis. I am knee arthritis now. You tell everyone, like you're like, I have a bad back. I can't do this because I have bad knees. I have a bad hip. And that starts to become a little bit of your identity. But we need to remember that just because there is something going on in your body, that there is some adaptation happening in your body at the tissue level, it doesn't define who you are and what you're capable of. Every single person's experience with pain or injury is going to be different, even if they have the same diagnosis on paper. An example I often give is, you go to your doctor because you've been having some back pain and maybe it's going down your leg a little bit, and you were told, okay, you have a disc herniation. You shouldn't bend forward anymore, right? That can be really scary to hear. But what we know from studies where they look at large populations of people, asymptomatic people, so people who don't have active symptoms, and they do imaging studies on these populations, they often find that a lot of these types of conditions, whether it's disc herniations, whether it's meniscal tears, whether it's rotator cuff pathology, whether it's degenerative disc disease, these are super prevalent in asymptomatic populations. That means people who don't have active symptoms. So a lot of the time it can be very scary to get this sudden diagnostic label, but at the same time, we need to recognize that these types of conditions, these adaptive changes that our body makes as we age, these are super prevalent in the population, right? So if your doctor says, oh, you have a disc herniation, you shouldn't bend forward or it will get worse, we need to remember that that is not the whole story. It can be scary to hear, especially, if that is something that is pushing your symptoms or spiking your symptoms. But at the same time, lots of people with disc herniations bend forward just fine, and they don't have any pain. They might even find it relieving. So these theoretical kind of mechanisms of things like, shoulder impingement is another one, for example, where it's like, oh, okay, don't raise your arms over your head or you're going to fray your rotator cuff if you have rotator cuff pathology. That is, well, one, that's pretty well dispelled in research. But two, a lot of these like theoretical mechanics are not the be all and end all of the situation. It's a lot more about finding what feels good, what movements feel right, what movements feel relieving to you, what movements are maybe a little bit provoking, and finding an entry point to those and then building up your overall resilience. So focus on what you can do, right? Try starting with smaller versions of movements. Try building from there. Focus on improving overall function without necessarily fitting into a single box of, oh, I can do this and I can't do this. The next myth I wanted to dive into, and we touched on this just briefly, is that imaging is not the whole story, right? So if your MRI shows degeneration, if your MRI shows pathology, your X-ray shows bone spurs, whatever it is, know that imaging and pathology finding on imaging is not a direct correlation with someone's symptoms. So I have had clients come in with very minor changes on their X-ray. So like very minor bone spurs, very minor joint narrowing in their knee, for example, which are all signs of osteoarthritis. And they come in with a very severe flare-up, like their knee is swollen, they're in a lot of pain, they're walking with a limp. And I've also had people come in with very severe changes on their X-ray. Degenerative disc disease, that's very obvious, a scoliosis or thoracic kyphosis, so like a hunchback, kind of a forward hump, that is very obvious. Osteoarthritis in their knees, so collapsing one way or in the other. That is like a very significant, not just on X-ray, but you can see it in the way that they're standing. And those people have no pain or have very minimal change or minimal pain, minimal symptoms. So imaging is not directly correlative to your pain, and imaging does not predict how much pain you are going to have. In fact, a lot of these changes that we see, like I said, these are just normal common signs of aging. The way that I tend to look at it is all of these, quote unquote degenerative changes, they're often our body's way of adapting adapting. They're our body's way of adapting to age, adapting to forces, adapting to things that are maybe not the most perfect mechanics in the world, or adapting to previous injuries. It is the body's way of trying to help you. Bone spurs, for example, is like, your body is trying to create more bone to help reinforce a joint that is potentially unstable or is potentially being overloaded. There's often a lot of genetic components to these too, but a lot of the time we can look at imaging in asymptomatic populations and find a lot of these conditions, which tells us that even if you do have pain, even if you're coming in with symptoms and you have these things on imaging, it doesn't necessarily mean that we need to fix the pathology or the tissue change on imaging in order to fix your pain, because we know lots and lots of people have these things on imaging and don't have pain. So I think it helps to reframe this narrative where it's not all about like fixing the tissue. It's not all about like trying to exactly fix what's going on the inside. It's about managing your symptoms. It's about building up resilience, and it's about exposing you to functional movements that we can progress over time so that you are capable of doing them. The next thing I want to touch on is pain. And pain often gets a bit of a bad rap simply because people think that it should be one-to-one. People think that it should make sense, and it doesn't. Pain is complicated. It's not just about like what's happening in your body physically. So if we have tissue damage, if we have injury, there are inflammatory markers that are making your nerves more sensitive. There are things happening that are overall making your body respond to pain. But then there's a lot of other things that layer onto it. Your stress levels can influence how much pain you're experiencing, how sensitive your body is to that. How much sleep you're getting can influence how much pain you're in. Your beliefs, whether you think something is going to hurt, whether you predict something is going to hurt, whether you think something is dangerous, your beliefs around pain and around movement can all influence how much discomfort you're feeling. And a lot of these things can influence how our brain interprets it. If you think of it this way, it doesn't exist at the tissue level. If I sprain my ankle, for example, and there's a lot of inflammation, there's swelling, there's a torn ligament, there's like real tissue damage down at the level of the ankle, pain doesn't exist there. What's happening is that all of those inflammatory markers, all of those biochemicals that live at the site, those are all making my nerves super sensitive. And the tissue damage itself is sending off signals called nociception up nerves called nociceptors. These nociceptors are triggered by what we call a noxious stimulus. That means something that is at a high enough level, a high enough force, a high enough output to stimulate this nerve to fire. Those nociceptive signals go up to your brain, and it's your brain that gets to decide how much pain it's going to interpret that as. Sometimes it makes sense. So like obviously something like a sprained ankle, usually it makes sense. The pain is relatively correlated with the amount of tissue damage. Sometimes it doesn't make sense. Headaches, right? We can have a lot of headache pain and no physical tissue damage. Paper cuts, another one. You put lemon in a paper cup. The lemon is not necessarily making that paper cut worse, but it does make the pain worse. So a lot of these like chemicals, a lot of these things can make the nociceptors more sensitive or can turn up the volume on pain. And because pain is interpreted at the level of the brain, it's your brain that gets to decide whether it's turning up the volume knob or down the volume knob. All of these other things that holistically are influencing us, like stress, like sleep, like nutrition, all of these things can influence how we're experiencing pain. So it's just good to remember that if you're especially dealing with like chronic pain situations, it's not always just about, okay, I got to fix the thing. I got to fix the tissue damage. I got to fix the arthritis. I got to fix the disc. Sometimes it's about, okay, what are these other levers within your life that we can pull? Can we get more sleep? Can we manage our stress a little bit? Can we manage our nutrition and eat some less inflammatory foods a little bit more and see how that influences our pain, and not always about just fixing the direct tissue source. So we've talked a lot about some of these common myths that come into, rehab and our experience of pain. Let's talk about what we actually do when we have an injury. So again, kind of coming back to that, like, imagine that your doctor just gave you a diagnosis of knee arthritis and you're kind of freaking out and you're like, okay, this is my whole identity now. What do I do? How do I stay riding? How do I keep fit? What do we do? Number one is looking at load management and activity modifications. So overall, looking at the things that are provoking your pain or provoking your symptoms in your life and looking at how we can modify them. Because remember, rehab isn't just about stopping everything that causes pain. It's often about how to adjust how we do certain activities so we can find an entry point. This is what we call load management. So I always think of it as like, if you say you get Achilles pain riding, and the Achilles pain only comes on after riding for about 25 minutes. Then it's like, cool, okay, if we know it's coming on after about 25 minutes, we need to lower what we're doing, lower the barrier to entry so that we're not pushing into that pain all the time. So we make it a goal. We say, okay, we're going to ride for 20 minutes. Or maybe we can modify other things. If you have Achilles pain, maybe we can try a different kind of stirrup, something that has a little bit of a different pad or a different angle that is offloading your Achilles a little bit and modifying things that way. So we can modify all these kinds of different variables. If you have pain with squatting, can you squat to a lower depth? Can you do less reps? Can you do a lighter weight? There's a lot of different things that we can play with to manage your load and find an entry point. But also remember that that is not the final stopping place, right? The idea is to lower the demands of the exercise or the aggravating activity so that there is an entry point that you can accomplish, that you are pushing into, maybe just poking the bear a tiny bit, but we're not punching the bear in the face. We want to find that entry point. We want to poke up to it, but then we want to allow our body to adapt, allow our body to desensitize, allow things to relax and heal. And ideally what happens is then the line moves. So if we push up to your line, if we push up to your symptom threshold, we allow the body to recover. Ideally, that symptom threshold moves a little bit. It gets a little bit more resilient. It gets a little bit less sensitive. And then we can push up to this new line. So if 20 minutes was what it took to flare up your Achilles, we ride, 25 minutes was what it took to flare up your Achilles. We ride for 20 minutes for a couple weeks, and then we try pushing to 25 again. Beautiful. Now your Achilles isn't flared up as much. So now we can push up to 25 minutes, and then a week later 30, and then a week later 35, and we can slowly rebuild you up to that point that you want to be able to do without flaring up and continually like poking the bear. Oftentimes, I think something that's really useful is breaking down our activities into like smaller and more manageable tasks. So like if standing for too long is what's causing your pain, can we take breaks and sit down? If squatting or lifting is what's causing you pain, can you try lighter weights? Can you reduce the range? Can you try reducing the intensity or lifting fewer times per week a little bit so that overall, gradually you're able to do more? I always think of it too, like if we have pain with a certain activity, it doesn't necessarily mean that you have to avoid that activity overall forever, right? It also doesn't mean that you have to avoid pain in that activity. At some point, we actually do probably need to push into things a little bit in order to force your body to adapt. But I do have a couple rules on loading. And again, quick disclaimer, this isn't medical advice. This is just like general rehab principles. First off, I usually tell myself tell my clients, barring, things that you definitely shouldn't push through, like bone stress injuries, stress fractures, genuine fractures, stuff like that. Typically, nothing is really off limits, but we do want to be sensible. So we can push into pretty much all kinds of activities as long as it's feeling okay, or even if it's feeling good. Even if it's not feeling good, we can push into a little bit of symptoms, a little bit of pain. But we do want to be sensible about how we're approaching that. Number one is that if pain is getting worse while you're doing something, if it is escalating, if there is no warming up out of it, it is getting worse, it is even becoming like less bearable, that is a sign that we are pushing too much. We don't want pain to be getting worse while we're doing an exercise, while we're doing something. If it's getting better, usually that's okay. Usually that's a sign that things are progressing in the right direction. So I will always tell my clients to say they have knee pain with squatting and they say, okay, well, I guess I shouldn't squat. Well, you just say, no, do a set of 5, do a set of 10, and see if it's getting better. If it's getting better, often, a flag that we can kind of keep pushing through. If it's getting worse, that is usually a sign that we need to regress something. Less range of motion, less depth, less weight, less intensity, something to offload that space a little bit. That is my rule on pain during the exercise. My second thing is pain after an exercise. So typically, if you do some sort of exercise, we want that pain to settle within a reasonable time frame. Say you go for a run and you have low back pain after the end of your run. If that pain is settling within a few hours, definitely by the next morning, I'm usually okay with that because it's a sign we poke the bear, we let it go back to sleep, we allow your body to recover, and it's recovering in a decent time frame. But if you wake up the next morning and that pain is worse, or your baseline is worse, things have flared up, that is a sign we did too much. It's not a sign that we did anything bad. It doesn't mean that we shouldn't go running. It just means that, I don't know, if you did 5K, maybe you should do 2K, maybe you should do 3K. We need to scale things back to allow the body to adapt a little bit. It's a little bit like, think of it as a scab, right? You don't want to be continually picking the scab, but eventually you do need to allow that body to adapt, allow it to heal. The next principle I want to get into is something called graded exposure. Often when we have pain, it's very easy to just start avoiding the activities that hurt, because they're painful, right? We don't really want to poke into something that hurts all the time, especially when like our typical culture is that we want to avoid pain or really any form of discomfort. But when we have a goal to get back to something, eventually we do need to expose our body to it. And that's where we go into graded exposure. So that's essentially just easing back into activities. So if you've been avoiding certain movements because they're painful, we need to slowly reintroduce them by finding that entry point. So say you're avoiding bending forward because it causes pain in your low back. What if you just bend down to a table? Can we do that? If you can't deadlift from the floor because it hurts too much, can you do a pull off the rack? So like a partial range deadlift. If you can't squat to the floor, can you squat to a box? If you can't ride for 60 minutes, can you ride for 30? Find a small achievable goal that you can actually achieve, that you can actually like serve as your entry point. Push up to that level, allow your body to adapt, and then push a little bit more. Another super underrated piece of the rehab process is sleep and stress management. And I cannot emphasize this enough because rehab and healing are two sides of a scale. One side of that scale is appropriate loading. It's appropriate volume management. It's appropriately pushing your body to adapt and handle the demands of what you are asking of it. But the other side of that scale is sleep and recovery, right? Because our body cannot adapt unless we give it the recovery to do so. If you load a tissue through exercise or something else, we are essentially breaking that tissue down. And that tissue will recover through sleep, through recovery. And so we need to give our body appropriate sleep and stress management to do so. You break things down when we are exercising, when we are loading, we allow them to rebuild with sleep. So if you're only getting like 4 or 5 hours a night and you're like, why is my knee never settling down? Why do I feel like I'm constantly flared up? Sometimes a very simple strategy that we can start with is just, can you increase your sleep 30 minutes, right? Can you go to bed 15 minutes earlier and wake up 15 minutes later? Can you do a wind down strategy so that you get better quality sleep? Can you make your room a little bit darker? Looking at these big picture principles to see, can we, if we can't necessarily, or we don't want to influence the one side of the equation, so the volumes or intensity side of the equation, can we influence the recovery side of the equation? Last thing I want to touch on is just movement. Again, it's really easy to avoid movement when things hurt, to avoid something that's aggravating. But at the same time, we need to remember that the best thing we can do to our body is to keep moving. Our body will only adapt to what we ask of it. And if we don't move, then our body is never actually going to adapt. And eventually it's actually going to decondition, right? Oftentimes people think, oh, I just have to completely rest. Like if I sprain my ankle, I have to completely rest. Typically, again, barring like something extreme like a fracture, we want to keep moving. We want to keep pushing things. And so we need to be able to progressively push what our body is capable of to allow those adaptations to happen. And that involves movement. We need to stay consistent, but at the same time, it's also totally okay to stay below your symptomatic threshold, right? Rest is typically not our best friend and often has a lot of detriments to it because it will cause us to decondition. Resting too much can typically make things worse, so we want to start with easing movement, like even a 10-minute walk, some gentle mobility, and gradually increasing time and intensity as we start to feel better. So just overall, remember it's not about just the exercises, it's not about just like acupuncture, heat, soft tissue massage, whatever. It's about making these small adaptations, these small progressive steps that add up over time. Remember to modify what you can. If something is too much, you can make it less. That's totally fine. Set your realistic goals so that they actually fit within your life. Control what is controllable to you, right? Because sometimes, again, you can look at all these levers we can pull and you can say like, okay, well, I'm supposed to be sleeping, 8 hours a night, but I have a newborn at home. That's not something in your control right now. What other recovery strategies are within your control that you can double down on? And sleep will happen, sleep will come, but fix the things that are fixable and try not to worry so much about what is not. And also remember to objectively track your progress, right? Whether it's just a quick little jot down of like the symptoms that you felt one day with a certain type of movement or a certain dose of exercise, a little journal, your pain levels, whatever. Having an objective measure that way often helps us recognize progression that is hard to see when we're living it day to day. So I hope you guys found that useful. Just remember, again, you are not your diagnosis. Imaging is not the be all and end all. Pain has a lot of pieces to it. Keep moving, stay active, please seek out the help of a professional if you are struggling, and be patient, because rehab is a journey. It is about small and steady progress. It is not a straight line. That is why it can be incredibly useful to have someone in your corner. All right, hope you guys are doing well. Again, if you found that useful, I would really appreciate if you could rate, review, comment, share this with a friend, and I'll catch you on the next one.